Good afternoon, everyone. We're kind of speaking via recording today, as unfortunately I can't be with you. But Nisha will be with you, so any questions you've got, please direct them to her and make them as hard as possible. So we're here today from Huddersfield, and we're going to talk about how we've delivered our day case knee pathway, both in the independent sector and in the NHS. And we're also going to talk about the digital edge we added to it that helped with patient rehabilitation and discharge. So for those that don't know, Huddersfield is a town between Leeds and Manchester, and this is the hospital we work at. It's called the Royal, and this is where we kind of do most of our elective patients. We all know that a huge amount of knees are done every year in the UK. This will inevitably increase due to the pressures of COVID and the elective recovery. And we know that patients can stay a variable amount of time in hospital, with the average being about 4 days. Some hospitals do a lot better, some hospitals do a lot worse. But what we know is post-operatively, most of the patients' recovery tends to be self-directed, and they have very few prompts to their rehabilitation. During the pathway, the patients can spend at least 5 occasions when they have to visit the hospital for physio or outpatients. And what we've looked at is how could we reduce all of this? So why do day case arthroplasty? Well, we originally started this at the Huddersfield Hospital. I have to call it that now because the BMI has changed its name. And it was part of the enhanced recovery pathway. We very quickly saw that discharge times rapidly went from 4 to 5 days down to 1 day, but we also saw that some patients were ready for discharge on the first post-op day. The team that we were part of grew in confidence that it would be possible to do a same-day discharge, and that's what we decided to do. So on a ad hoc basis, patients were going home on the same day. But surrounding this, we realised that actually we needed to put a little bit more governance around this, and we formalised a pathway probably about 40 months ago, a pathway which we've since shared with other organisations on our local trust. The digital pathway was essentially a kind of something that I wanted to do because my other role as well as a surgeon, I'm a Chief Clinical Information Officer, and everything digital appeals, and it was how could we use technology to enhance the pathway, and that's where we added the wearable technology to our patients and did our successful pilot. So what is the digital pathway? Well, it was a collaborative work we did with the independent sector, with the Trust and Lacala. It initially focused on a group of 25 patients. The patients would have a wearable device that would monitor their rehabilitation, and there was a real strong focus on involving the staff and the patients in this journey, and knowing that digital would enhance this. We had a huge amount of input from BBRON with the wearable sensors, and we also worked with them to improve some of the technology. The enthusiasm of the staff was kind of probably the biggest thing, and it was probably relating to that we managed to get from the inception of the original concept to the first patients going through. It took 6 weeks, which I think in any project in the NHS is pretty remarkable, really. The pathway was, it looks on paper quite complex, but we felt it's important to map every stage out because everybody in that pathway, every person that sees a patient has the ability and the authority to say the patient isn't suitable for the day case pathway. So the process, and this is Nisha's idea, we broke it down into lots of P's. We identify the patient, there's a pre-assessment, and plan the list. Obviously the patients need to go first or second or third on the list. We prepare for the day, the procedures carried out and the post-op care is carried out, but the physios and the pharmacists are equally as important along the way, with the pharmacists having pre-bundled medication that can be discharged, so there's no delay there. From my perspective, it starts in the outpatient. We have a relatively simple inclusion and exclusion criteria, which has changed over time, with the main essentially being a patient lives alone. They certainly can't go home. We introduced a concept to the patient. The patient needs to be confident it's safe to go home the same day. And I think the key is the team. Its success is very much dependent on the delivery of that team. If anybody along that pathway highlights a problem, the patient themselves would see that it wouldn't be a great idea. And the patients, if selected or if suitable, and then entered into a bespoke pre-operative pathway. And again, I kind of reiterate that anybody along the pathway can take people from the day case route. So I'm going to hand over to Nisha now for the next slide.
So this is our original exclusion criteria slide. When we started about 3.5 years ago, uh, our exclusion criteria was very long list of patient conditions. But as our experience grew and team's confidence increased, now the absolute exclusion criteria is one, that patient should not be living alone. He or she should have some support at home. All other chronic conditions, we have, with our experience, we know that they can't be changed overnight, and patients are very much stable with those conditions. Then we go ahead and do the day case name. Once patient is selected to be suitable for day case knee replacement, all these patients are invited to one-stop pre-assessment clinic. In that pre-assessment clinic, anesthetist is present. There is advanced clinical practitioner, ward sister, therapy team, pharmacist, as well as BBRON rep to help. This is for digital day case criteria to help with the census. The entire pathway. First of all, I see the patient and make sure that medically he's still suitable, motivated, and appropriate to go for as a day case. All the pre and post operative care plans are discussed along with physiotherapy, pain relief, and nursing team and pharmacists also take the detailed history and make sure that patient is suitable. On that day as well, if any of the team member thinks that patient might not be suitable, then we take that patient off from the day case pathway. But the actual key to success is patient motivation and agreeing to be part of day case pathway and get involved in their own care. And that was the huge success which motivated, and we got so many cases done.
So, day of surgery, it's largely unchanged. This is not about the surgeon. It's not so much about the knee testing. Again, it's about the team. We use, we've always used kind of a high functioning joint implant, whether it's a uni or a total, and we don't distinguish patients on the basis of what implant they're having. I reduce the tourniquet pressure. It's very trendy to remove tourniquets completely, but I do find that having a bloodless field is very important surgically and certainly for cementation, and therefore by reducing the pressure, it reduces the thigh pain that a patient would traditionally have post-operatively, but gives me enough vision so I could do the surgery safely. We have a reproducible theatre flow, and what I mean by that is everybody works together, everyone knows the next step. Because we are using low dose spinals, we can't have a surgery that can vary between half an hour to 3 hours. We have to know how we all work together, and surgery pretty much takes the same time. I use a pretty waterproof dressing, which is fantastic. It means that you don't have big bulky dressings on, and then you can observe the wound without having to disturb the dressing, and the patient, more importantly, can wash. So they can wash the horrible betadine smell off them, which again lessens the impact that the surgery has on them. I don't use drains, and I hope nobody still does. And we've done away with woolen crepe because what we found, it was a barrier to movement. When we removed it, we found that the cry cuff could go on very early, the patients could get moving, and we didn't see any downtime. But again, reiterating what we've said before, we make this about the patient. We try and normalize the surgical experience as much as possible. And there you go, because it's a video, we can do some fancy stuff with highlighting that last point. This is a picture actually of the very first digital day case we did. These two patients are kind of poster boys. It turned out they were all school friends and went to teach at college together, and they met up on the day of surgery. So I think it's quite a nice picture, and we send it everywhere. So back to Nisha. She's going to talk about anesthesia.
So this is very important. On the day, I make sure that patient is well hydrated, drinks water up to the point of surgery, and when they come in, they get immediately their pre-med, which is I use oxycodone MR and omeprazole. All the patients get low dose spinal anesthesia of heavy prilocaine with diamorphine. Obviously, recently there is acute shortage of diamorphine, and I'm trying to move to fentanyl, but not done enough cases with fentanyl, so I've not put up in the slide. Intra-op, all the patients are again, they all get IV fluid sedation as well as IV paracetamol, ondansetron, and dexamethasone. I believe in giving two antiemetics because patients do get, they are starved, they get opioids, they are anxious, and post-operative nausea and vomiting can delay post-operative physio and discharge. Once the surgery is done, obviously during the surgery, Graham does infiltrate generously uh, the mixture of chirocaine as well as adrenaline, and that has been really good. I have never had to think about doing any sensory or motor block for the knee replacements. Once patients are in recovery, we do offer oral fluids. We do HIMIQ there, and directly from post-operative care unit, patients go for X-rays, or we do X-ray, mobile X-ray in recovery area. Once they are back on the ward, they eat and drink, and by the time during that time, the spinal anesthetic starts to wear off, and then the therapy team and nursing team takes over, and patients are discharged.
And I think that the point about blocks is really important. We don't say, day case is just about not giving blocks. It works in some units, it works for others, and you'll have heard today an awful lot about blocks. For us, it's just not something we've needed. But it's part of that armamentarium that some units will certainly do well with.
So, all the patients post-operatively, obviously, when they go on ward and the spinal wears off, these are the post-operative analgesia which I prescribe, and they go with the Cardex as well at home. They all get oxycodone. Tramadol if they are already on, because oxycodone I give maximum 3 doses post-op and then it is stopped. It's not continued with GPs either. So I have not seen any opioid dependency post-operatively. Paracetamol, Lectulos obviously for obvious reasons, and these are PRN drugs.
And I think these are medication. I think one of the keys to this is being very prescriptive to the patients. There's no good taking painkillers when you're in pain. It's about being on top of the pain before it happens. And this is partly why day case works. In a busy unit, when a patient stays overnight, the nurse might not get to the patient in a timely fashion due to other jobs. But when they're managing themselves, they can give the painkillers at the right time. And I think that does make a big difference. We have a nurse-led discharge criteria, and they have to tick the boxes to make sure the patient's safe. Sometimes these patients may be discharged before we finish in theatre, so waiting for us to come up and say goodbye is not necessary, and I think this works well. What does wearable technology offer? Well, it's great because the patient can wear a sensor, they can see the range of motion post-operatively, they see goals, they can target a different goal every day, and they can see progress. That's something you wouldn't see if you're self-directed, not getting the advice. Daily, you can log your pain and discomfort. Physios can be accessed through the portal and they can ask questions, and that has proved really important. The key to this is the patients feel as though somebody's keeping an eye on them, and if we do need to intervene, if a patient's not doing so well, we know who we need to intervene to, so the right patient gets the right care at the right time. Follow-up, not always possible, but if we can, we try and do a remote follow-up. Having the wearable information tells us that a patient's progressing well. We don't necessarily need to examine them in clinic, but we can use video consultations. We certainly do a pilot of the trust using Andor platform, which is something that adds to Teams and makes it better, if you like. But that is certainly something we're working on because we can add extra bits into that consultation to enrich that consultation. And I think as we move forward, virtual is more important. It's becoming more important. I think the elective recovery is also asking us to do at least 30% of our visits virtually. So I think this is also an area where we can improve on. So we've done quite a few now. I think we're up to 259 cases. Some of those are the digital. I think the other variables are pretty much the same, but I think the key is it's not just unis, it's totals, it's revisions, and it's complex. The surgery is irrelevant the key is the rehabilitation and the team, and therefore people often say, I'm going to start with unis and move on to totals. It hurts the same. Revision hurts the same as a total. Just get your patients going and get them moving. The average time from admission to discharge is 11 hours, with 7 hours being in hospital. The phone call is really important. Patients, we need to make sure they're doing well, but the patients also need to make sure that we're monitoring them, and I think that's really important. Quite often sending patient home is seen as you're pushing a patient out of hospital, but actually what we're doing is we're kind of, it's almost like a virtual hospital. We're managing them at home, and we're looking after them as well, and their patient knows that we're there for them if they're needed. We've had very few concerns. A few patients were nauseous and had some pain, but that's easily managed with the regime we have. They can ring the hospital and we can alter the medications appropriately. Complications are fairly infrequent. There's urinary complications. We did have a run of the dressing creating blisters. This unfortunately was my fault. I let a relatively inexperienced staff put the dressing on, and it's a learning curve to use this dressing, and putting too much on can cause blisters. We don't see those anymore. I think this is a really interesting slide. Is this because of us, or is this because of the patient's perception? But we found that pre-COVID, about 35% of our knees went home as day cases. Post-COVID, during that period, 56%. Now, is that because we wanted them home because we realised that it's not safe to be in a hospital, or is that patient's perception of being in hospital has changed during COVID, that they now want to be home? So I think that's really important, and I think that just shows the possible. 56% is a big figure, but it's a possible figure. We're not quite there at the moment. As we've expanded to more of our patients, we're probably just dipping below the 50% mark, but I think it's achievable, that we can aim high and we can get most of our patients home as ambulatory knee replacements. The results from our pilot, which is interesting, just going to be published in the journal, the American Journal. We've 21% of our patients were included, and the others were excluded mainly on technical reasons because of the technology. We found the compliance was really good from a digital pilot. 62% compliance, we would believe, is excellent, and that's really important. We found that if a patient used it on a daily basis, they progressed really well. We found that they started obviously with a poor range of motion, but after 7 weeks, the average range of motion was 136 degrees, and if they used it consistently, they would achieve that target a lot quicker. Daily compliance was testament to that. But the patient's feedback was awesome. They really loved it. It really helped them know where they were going and if there was a problem. Benefits, what can it offer? Well, it can reduce the amount of therapy sessions, which inevitably will reduce cost. It increased compliance with exercise, and because the physios could monitor it and they could get in touch with those that didn't. We saw using the sensor could reduce the cost to therapy services post-operatively, and the therapy service, not just us, but the therapy services are confident they can reduce that further. The hospital is going to benefit. You're reducing the length of stay, and the length of stay every night has a cost. So you can make huge cost savings by reducing a length of stay simply by 1 day. Both the day case pathway and the wearable technology allows that. And if you look at how we need to improve some of our kind of length of stays with post-COVID to free up some beds, then this is a no-brainer really. And patients, this is the most important thing. They loved it. They felt part of a team. They felt we were monitoring them. They wanted to achieve something for us as much as they wanted to achieve it for themselves. The waterproof dressing was a game changer in that it meant I wasn't worried about wound ooze. I wasn't worried about wound problems or wound infection. Patient could go home safely with the wound. We found that the message and the goal setting really improved satisfaction, reduced some of the dissatisfaction. Patients love the ability to message the physios. Physios were worried it would take a lot of time out of the day, but what we found, it didn't. Very quickly after using it, physios found it would just take 5 minutes to answer a few questions, but gave them probably hours back in the time that they may have spent on the phone, or the patient spent on the phone trying to get in touch. The virtual clinic is a no-brainer, reduces hospital appointments, and I think all of this pathway really reduces benefits in social distance, in the COVID era, and probably now as we move into elective recovery is going to really benefit that. These are a few of the comments from patients. Universally they loved it. There was one patient wasn't so keen because she couldn't connect it, and I think she found that the wall was a good way of trying to sort the connection out, and she managed to break the device by throwing it aggressively against the wall. But she was the only one. She's since calmed down and got another sensor and was happy with that. So these are a few videos of some of our patients. This is our poster boy we showed you on that picture. You know, I think he.
It was interesting. It was of something a little bit alien. I didn't expect to go home on the same day. When it was explained to me and the reasons for that, it did make sense. So it was, again, for my recovery, I think it was good.
And this is a bit of an advert for Bubron.
Thanks to BPM Pathway, I was discharged early. At 3 weeks post-surgery, I was able to be back out on the field coaching rugby, which is what I love. I was on the field, not sat in the car, and taking a full part in a training session.
Well, I think, just in case you didn't believe him, this is generally him at 3 weeks post-operatively from, he was a uni knee, and this was him at the local school training the kids. So there you go. So what are the benefits? Well, day case surgery, there's obvious benefits. We heard a lot today. Adding digital to that drives some more patient satisfaction. You know, patients take ownership of the care. They become part of the team. You know, they have better outcomes because the technology helps deliver this. We reduce bed days with the potential, and I think a real potential, particularly now, and I think probably some conversations you've had today have alluded to this, that, you know, ambulatory arthroplasty units are a thing that we need to be looking at now and certainly really focusing on. We'll reduce unnecessary hospital visits. The cost of care is inevitably going to reduce to the back of this, and it's a reproducible pathway. It's not something special to me as a surgeon or Nisha as an anaesthetist, or, you know, the Huddersfield Hospital as a hospital. This is about a pathway that can be shared with others and can be reproduced. The key to this probably is visit. You know, we're happy for you if you want to visit and come and see what we do, because I think that just gives you an overview. And I think the BPM pathway is really important. We've just recently published this on, well, I'll say NHSX. It's now NHS Transform. It's one of their digital playbooks. So if you want to learn more about that, you can go on the NHS digital playbooks, and that will talk. I should give you some information on what we did there. So that is pretty much it from us, from a recording point of view. And what we're going to do now is we'll go live and hand over to Nisha, who will be there to answer any questions.